Okay, this video is going to cover a lot of areas, pretty much the rest of the CPT to radiology. Why your textbook puts all these together, I don't know, but they do, and so now that's what we got to do. They're kind of small sections, but it's just a lot of sections, so you don't get too stressed about it. It'll be okay. These first few sections kind of follow on the heels of the urinary. We're going to specifically look at the male genital, then look at the female genital, and go into maternity, and then nervous, and then eyes and ears. Eyes and ears are probably the easiest of all of it. So here's the male genital. Starts with the body parts. And again, these are not long sections, so probably the whole rest of this is about like the cardiovascular together, but it's just going to seem like a lot because there's so many different parts. Again, here's a great page to do some drawing, making notes on. The male genital section will start at the outside of the body and then go in, so it starts with the penis. Incision, destruction codes, excision codes. Here's where you will find your circumcision codes. On your circumcision codes, make sure that you're taking note of any age, like 54160 is specific to 28 days or less. So kind of watch that. You have clamp devices, you have regional blocks, that kind of information that you have to glean from your scenarios. Different introduction codes. Repair codes are open. A manipulation, this is if maybe after a circumcision the foreskin's kind of grown back, they have to kind of jerk it free. That would be what that would be. Then we go into testes, excision codes, repair codes, laparoscopic codes. Specific, the epididymis, the tunica vaginalis, scrotum, vas deferens, spermatic cord, seminal vesicles. There's a few prostate codes in here, just a few. The rest of them, of course, are in the urinary section. Not too much notes in here. Again, it's finding your body section, then your specific body part, and then the action on that body part. Under prostate, you have some excision codes. These would not be TURPs. The transurethral, these would be actual open removals of the prostate, laparoscopic. Other procedures, these are different, maybe radiation devices put in because of prostate cancer, placement of catheters for maybe they're putting the seeds into the prostate to treat it over a 4, 5, 6 month period. That type of thing. Your reproduction codes and your intersex codes. There's only two. You can only go male to female or female to male. So those aren't too difficult. Your book goes into graphic detail about the intersex surgeries. First time I've seen that. And that's it for your male genital. See, there just wasn't too much there. Female genital, short too. Again, you have your great page for notes, your different table of contents, a little bit more in here because we have maternity care put in here as well. So again, the female system, just like the male, is going to start on the outside. So you start with the vulva, the perineum, and the opening of the vagina, which is called the introitus. Here are different definitions of vulvectomies that are done to what the extent is. Your doctors should document whether it was deeper than sub-Q, whether it was 80% or more, whatever that is. They should document that. So for this body part, we have incision, we have destruction codes. These specific 56501 and 56515 are specific to destruction of lesions on the vulva. They're either simple or extensive. Again, that's based on your documentation. excision codes, repair codes. Then we go straight into the vagina. Incision, destruction, excision, repairs. And here is where you may find like cystocell and those types of repairs. Anterior colporaphes, having to go in and sew up part of the vagina, either on the anterior front side or the back side, posterior. That's what you're going to find in here. Laparoscopic codes for the vagina. Colpo, C-O-L-P-O, means vagina. So colposcopies or coloscopies. No, colposcopies. I knew I said that wrong. Colposcopies is would be scopes for specific to the vagina. Then you get into the uterus, specifically the cervix part of the uterus. Code 57520, 57520. This conization of the cervix. You might see lingo like loop, L-O-O-P, or leap, L-E-E-P. And this procedure also includes any fulguration, which is destruction, any D&C, dilation and curettage, and any repair. That's all a part of that particular code. Then we get into the body of the uterus. This was the cervix part of the uterus. Now we have the body part of the uterus. This is where your hysterectomies will come from. You can have, these are all open, or from 585, I said that wrong, 58150, 58150 to 58240 are an open approach. Code 58140, you do not use a 50 modifier if the ovaries or one ovary is removed, because it gives you the plural, so it's bundled in. Starting with 58260 is your vaginal code for a vaginal hysterectomy. So these are abdominal hysterectomies that are open. These are vaginal hysterectomies. You have your introduction section, laparoscopic section. We go into the oviducts, which are the tubes, fallopian tubes, and the ovary. They're kind of combined together. 58600 is a sterilization code, ligation and or transection of the fallopian tubes. This is when they're, ligation means tying off, so this is a tying off of tubes when you have your tubes tied. 58611 is when you have your tubes tied at the time of cesarean delivery. You have laparoscopic codes specific to this body part. So you're going to see cystectomy. That's not cyst or cysto, meaning bladder. Can also be cystectomy, meaning a cyst removal. So just kind of keep that, really watch those terms. Ovary section. We have some in vitro fertilization, very, very, very specific codes. Then we get into our maternity care. So there's three parts of maternity care, and that's kind of what these guidelines talk about. You have antepartum care, which is while you're pregnant, baby is still inside of you. You have your delivery care, that's getting the baby out of you. And then you have your postpartum care, which is up to that 6 weeks, 4 to 6 weeks. So you have to know these different components of maternity care in order to find the codes correctly. So here's some amniocentesis or chordocentesis codes, different invasive, fetal invasive stuff. Code 59120, 59120. This is a surgical treatment of ectopic pregnancy. This could be an open or abdominal approach, or it could be a vaginal approach. Either way. Laparoscopic type of codes. Then we have our vaginal delivery codes, our cesarean delivery codes, and you'll see them. They're kind of divided. Like for code 59400, this is routine obstetric care, including antepartum, vaginal delivery, and postpartum care. So if everything was uneventful, then the physician or the obstetrician is actually going to kind of bill as a bundle. So much money for that 9 months of care, or that 7 months of care. Usually it's only about 7 months. Your code 59409, 59409, this is a vaginal delivery with or without forceps. This includes your vacuum extractor. When they have to put the little vacuum on the top of the baby's head and help pull it out, they don't do forceps quite as much as they used to. And then it kind of divides up. Maybe like with code 59414, patient delivered maybe in the taxi cab on the way over. So all the doctor did was deliver the placenta, you know, that kind of thing. They're just weird scenarios. Same thing with your C-section. You have to kind of know, did the physician provide the antepartum care, the delivery, and the postpartum? Did they just do delivery? That type of thing. Delivery after a previous C-section, that's its own section. We have our abortion section. Abortion these days includes all miscarriages. We used to use that. They just don't use that so much anymore. Two different kind of help with understanding the difference between an incomplete abortion and a missed abortion. 59812. This is an incomplete abortion or a miscarriage. And you didn't, or the female did not expel all the products of conception. So there's some retained parts still in there. They're probably going to have to go in and do a D&E or a D&C. 59820, this is treatment of a missed abortion. The baby has died. There's a fetal demise, and they're going to have to go in and completely take out the baby. It just, for whatever reason, the body didn't expel it once there was a demise. Okay, so that's it for maternity, female and male. The very back part of the female is the endocrine system. So this is the thyroid gland, parathyroid. We'll get those in a minute. A couple of things I want to tell you about the thyroid gland. You have to know the anatomy of it. It's two different lobes. There's a left lobe and a right lobe. So if they are removing a lobe, that may not be a total thyroidectomy. It just may be a lobectomy. So you have to kind of know what you're dealing with when you read your scenarios. So looking at code 60210, this is a partial thyroid lobectomy, unilateral. That means it's either on the left or it's on the right. So you've got to use your left and rights. 60220, total thyroid lobectomy, either left or right. So the difference between these two is part of a lobe was removed on one side, all of a lobe was removed on one side. Then you have your 60240, which is a total thyroidectomy. That means both lobes, both sides, everything's gone. So that's the difference in these. So think about that. 60252, thyroidectomy, total or subtotal for malignancy. Very specific, for malignancy. Then 60260, thyroidectomy, removal of all remaining thyroid tissue. This means they've been operated on before. Okay? Moving into your parathyroid, thymus, adrenal glands. Very few codes in here, and very, very specific codes. So now we're moving into the nervous system. Woo-hoo-hoo. See, they're short, but you know, they're not too bad. So here's the nervous system. We have our table of contents, great pictures of the nerves, great pictures of the brain, great place to write notes in. Okay, like with most of the sections within the CPT, the nervous system is going to start at the top, which is the skull, the meninges, and the brain. There are 3 levels or 3 layers of meninges. The outer layer is the dura mater, middle layer is the arachnoid, inside is the pia mater. Okay? Injections, twist, drill, burr holes. This is gonna, you guys are gonna kind of have a little bit of head swimming like we did with cardiovascular. Just take it term by term. Don't get too far into the weeds with this. We'll come back to nervous system. There's a few words in here that I keep written down because I, just don't use this section that much, so I like to always know what I'm dealing with. If you see trephine or trephination, that means they're making a hole. You have craniectomies and craniotomies. Again, like 61510, this is a trephination, so they're making a hole here. On 61512, they talk about supratentatorial. This is above the cerebellum. So you might want to come back over here, look at the cerebellum. So supratentatorial is above the cerebellum. Looking at code 61518, infratentatorial is below the cerebellum. Okay, skull-based surgery. We're not going to get too much into the weeds. This is very, very, very technical neurosurgery type of lingo. So let's keep it simple. In order to perform skull-based surgery, you have 3 different parts. And that's what I try to do in some of the harder areas, is kind of have a 1, 2, 3, 4, 5 step or whatever. Pick out that information, and then you've got a really good chance of getting the right code. Here, the book kind of does it for you. You've got your approach, your definitive procedure, and then your repair reconstruction procedure. You probably will need a code out of all 3 of these sections in order to accurately code a skull-based surgery. So here's your approaches. This is number 1. You've got anterior, middle, or posterior. So look for that lingo, plug it in. That's your first code. Definitive procedure. You've got base of anterior, base of middle, base of posterior. Plug in that information, you have your second code. The third code, which you may or may not have, this one's a little iffy sometimes, is that repair code, and there's only 2 to choose from. Okay? Don't think about it any further. Do that 1, 2, 3. I labeled mine 1, 2, 3. Glean out that information and then call it good. Endovascular therapies. This is different angioplasties, different balloon dilation type of therapies within the cranium. Anytime you see intracranial, that's in the skull, somewhere in the brain, somewhere in the head. Intracranial, brain, head. You have, just like in cardiovascular, you have different aneurysm type of codes. Thank goodness there aren't as many. Couple of notes in here. With your stereotaxis, you'll see the lingo with this sometimes say stealth, kind of like the stealth bomber that we have in our military, stealth, S-T-E-A-L-T-H. So that will be kind of a clue that you're in this area. If, and like I always do, I always write me little cheats so I don't have to go hunting for codes. If stereotactic, oh, I didn't even spell that right. If stereotactic CT localization was used, then you're going to need code 77011. Stereotactic CT, CAT scan, localization 77011. Then over on this page, I do have a note up here that if craniotomy is present and craniectomy is present, both of those lingos are present, you're going to code only the craniectomy code. So if there's craniotomy cutting into the cranium and a craniectomy, that's a removal of part of the bone, may only be temporary, code only the craniectomy. Your stereotactic radiosurgery is your radiation. type of surgery. So just kind of put a note there that it's radiation. You have intracranial, this is a great picture, intracranial neurostimulators, repair of different intracranial issues. Cerebrospinal fluid shunts, these are hydrocephalic kids and adults that have to have a shunt put in the ventricles of the brain to drain off excessive fluid, cerebrospinal fluid in the brain. And it ends up going down the spine. This is a great picture. So the fluid collects here. It gets shunted down into the abdomen and then it is absorbed within the abdomen. Okay, so that's it for our brain. Thank goodness, right? Now we're into spinal cord. There are 4 different pieces of information that you need to pull out for these injection and drainage codes here. First, you have to determine your anatomical site. Is this, let's look and see what our choices are. Is it a spinal puncture? Is it epidural puncture? Is it a lumbar epidural? Is it cervical epidural? See what I'm saying? Then you need to know, was it diagnostic or therapeutic? What type of substance was put in? Was it for pain relief? Was it a steroid for inflammation? Was it an anesthetic for numbing? And then, is it a continuous infusion? Those are the 4 pieces of information you need to know in order to get these injection infusion codes correct in here. I do link up code 62270. I link that up. That's a lumbar puncture. Patient comes in with the worst headache they've ever experienced and their neck is stiff. First thing that the docs are going to do is do a lumbar puncture because they're going to either rule in or rule out meningitis. Those are the classic symptoms. So I go on and link up this cell count for that lumbar puncture. Chances are you wouldn't ever use these together because the labs code separately for their stuff. But at some point I had to have both of them, so I'm a linker anyway. I like having one place and the other place matching. All right, catheter implantation. You can use code 51 in here for multiple procedures. If you use these catheter implementation, you also code for the catheter placement. Now we're getting into back surgeries, more to do with the discs in between the vertebrae than actual vertebrae, but there is some work on the actual bone, the actual vertebrae here. You need to know your approach. This is a posterior, and I circle my approaches. This is a sideways or through the ribs approach, and then this is an anterior approach. So I circle those so that I can tell if the patient's laying on their belly, then it's a posterior approach. If they're laying on their back, it's an anterior approach. So then I know I can at least narrow the playing field with my approach. Then what I do in here, you have laminectomies and you have laminotomies. Again, just like the craniotomy and the craniectomy, if you have a laminotomy with a laminectomy, only code the laminectomy because they had to cut into it to get it out. Okay, the laminotomy would be bundled. But if they just did a laminotomy, then you would code for that. So I underline like code 63001 laminectomy, 12's laminectomy, 15's laminectomy, 63020 is a laminotomy. I underline those so my eyes are clearly seeing what the actual word is with the correct suffix. There's laminoplasties, which is 63050, and I kind of do that throughout my anterior. Your anterior approach will have lingo like discectomy, Vertebral Corpectomy. Corpectomy is the body of the disc, and it includes the disc removal. So the corpectomy, there's a little bit more removal that's done with the body and all of the external parts of it than just removing a disc. I do kind of bubble. This is the only bubble I think I have in the entire CPT, and it reminds me of a cartoon bubble. If these discectomies are followed by an arthrodesis, arthrojoint desis fixation, so that's your spinal fusions, then it tells you to go pick those up in the musculoskeletal. So remember when we were musculoskeletal and I said, and we made notes that you may need to go to the nervous system? This is where you may need to go. So I make that very, very clear to myself that I may need to go there. Okay, so then we kind of get in a little bit of some hunting and pecking. So here are some incisions, laminectomies that are done specific to the lamina, this specific approach, which is lateral or extracavitary or cavitary. Stereotactic, again, this is our radiation type of surgeries. We have neurostimulators for the spine as well as neurostimulators for the brain. Then we get into, we're kind of out of the spine now, and we're in all of those peripheral nerves now. This is where you're going to find digital blocks, regional blocks, epidurals are in there. Any kind of block outside, extracranial, so outside of the head. Anytime you see the word nerve block, that's also going to, it could be the same as a regional block. You may see regional, so you need to interpret that as a nerve block in here. So we have our somatic nerves, which are voluntary. Within this section, again, you kind of need to know what type. Like if you look at code 64400, this is an injection of an anesthetic agent, so that's a numbing, into the trigeminal nerve. Specifically facial, greater occipital, vagus nerve, phrenic nerve. Okay? The next section here is your sympathetic nervous system. These are responsible for involuntary movement. And if you look at these, starting with code 64490, they're diagnostic or therapeutic, with or without image guidance. If you just kind of, these are a little more vague. So they are specific to your paravertebral facet joints. And what is this one? Yeah. Then we're back to sympathetic, but these are involuntary. That may not even matter to you. I do it just to keep my mind sharp. Neurostimulator for peripheral nerves. So we had neurostimulators for a brain, we had them for a spine, and now we have them for peripheral nerves. Different destruction, neurolytic. Those are destruction, nerve destruction codes. Very, very technical again in here. Neuroplasties, these are surgical repairs of nerves. Plasty means surgical repair. Transection or avulsion, these are surgeries that remove nerves. Neuroraphy, these are, raphy means suture or sew. These are sewing of nerves. For these different nerves, I have found myself in here looking for a Morton's neurectomy that you actually will find with code 28080. Don't know if ever in your life that you'll encounter that, but that's why I have that note, because I must have been in here looking for a Morton's neuroma, and it was actually in a different section. It's the only reason that's written. Okay, that's the end of nervous. We are going into eye. And then from eye, we go into ears. So here is the eyeball. This is all going to be, it's eye and ocular adnexa. Ocular adnexa means everything outside of the eyeball. Uh-oh, I guess I better quit moving my hands so much. A couple of terms. If you have like 65091, evisceration, that means the eyeball's been drained, eviscerated. I hear that a lot on my NCIS and on Bones and all the shows I watch. Stuff's been eviscerated, all the blood's been eviscerated, that means all the blood was drained. But here that would be all of the fluid within the eyeball was drained. 65101, enucleation. This means the eyeball was removed. Enucleation is removal. So there's different removal of foreign bodies. Now this is the eyeball. Laceration, which would be terrible. Then we get into the anterior segment of the eye. This is still within the eyeball. Well, it's the anterior segment of the eyeball. Has the cornea in it. Specific to anterior chamber type of codes, the anterior sclera, iris, lens. This is all the anterior section or segment of the eye. Place where you need to write some notes. Intraocular lens procedures on page 415. This is surgeries for cataracts. Looking at 66982, I put ECCE. It's extracapsular cataract extraction. Extracapsular cataract extraction. Please underline complex because 66982 is rarely used. Only if the physician states it's complex. The ECC extracapsular is usually, the code for it is usually 66984 for ECCE. It includes the operating microscope. It's bundled in, so make a note of that. Your 66983 is your intracapsular. So one is outside of the capsule and one is inside the capsule. That's the difference. ECCE includes, and these are big technical terms, but I wrote them down so I don't get tripped up because you're going to see these terms within the surgical report. ECCE, extracapsular cataract extraction, includes iridectomy, cutting into the iris, iridectomy, trabeculectomy, cutting into the trabecula, iridotomy, or that's removal, sorry. Iridectomy is removal of some of the iris. Trabeculectomy is removal of some of the trabecula. Sorry about that. Iridotomy is a cutting into the iris. You got to cut into stuff to get an ectomy a lot of times. And anterior vitrectomy. So the vitreous fluid, there may be a removal of some of that. Body will make it back. Your 66985. This is a lens prosthesis going in. Not done at the time of a cataract removal. Not done at the time of a cataract removal. That one gets kind of misused some. Okay, so now we're into the posterior segment of the eye, which is all of this big bubble part. So we have the vitreous humor, or the vitreous, the jelly stuff. We have the retina. Then we get on the outside of the eyeball, ocular adnexa, ocular adnexa. So your ocular muscles, this is where you get cross-eyed, strabismus, or lazy eye. This is where you would find all of that. That's a problem with the muscles of the eye, not the eyeball. So all of the strabismus surgeries are in here. Really good pictures that we didn't used to have. Orbit, which is the socket of the eye. Eyelid issues. This is if you have entropion or extropion. This is where you would find those particular procedures. See, here's your entropion and extropions. Your conjunctiva. Conjunctiva is actually connected to your upper and lower lid. but it's the part of the eye that you get pink eye in. Very, very common. It's kind of the first defense before the actual eyeball gets hurt. But any conjunctiva, lacrimal system, this is your tear ducts, still on the outside of the eye. And we are into our ears. Yay! We're almost done with the surgery part of CPT. Okay, so we have 3 sections of the ear. We have the external ear, which is the pinna, that cartilage on the outside, all the way to the tympanic membrane. So that's what this section deals with, is the outside ear all the way to the tympanic membrane. If you see words like myringotomy or tympanostomy, these are incisions of the tympanic membrane. Myringotomy is the tympanic membrane. Tympano or tympanostomy is making a surgical hole within the tympanic membrane. Middle ear, this is where kids have tubes put in. This is a great picture. So external is all the way to the tympanic membrane. The middle ear is just this section, and then you have your inner ear. That's a very good picture. In the middle ear, if you see words like equalizing pressure or ventilating, those are the same thing. Ventilating means pressure equalization. Just a note for 69433, tympanostomy includes that myringotomy. You have excision codes, middle ear, repair codes, middle ear. Then we get to the internal, or the, inner ear. Sorry, I said internal. Fenestration, 69820. Fenestration means there's a hole and they're destroying that part. Fenestration of the semicircular canal. This is where the cochlea is, the inner part of the ear. Then you kind of have a little bit of the bone structure. The bones aid to the vibrating, which is what the nerves need to work. So some of that nerve stimulation vibrates off the bones. And these 4 codes are specific to the nerves within the ear. Then your operating microscope, which we add on lots of different procedures throughout the whole surgery section, is right here, 69990. So that is it. You have completed the surgery part of the CPT. We will begin the radiation, or no, that isn't true. Begin radiology, pathology and lab, and medicine. And then we will have cracked the CPT section.